By 5:32, they got an AT gauge saline lock in his left AC, gave him aspirin, 324 milligrams PO. By 5:33, they gave him nitro 0.4 milligrams sublingual. They administered it with relief. Patient reported a 7 out of 10. By 5:40, nitro 1-inch paste administered to the chest. By 5:47 through 5:49, it was a little vague there. Patient sat up, grabbed his chest, and says, "Oh." They started no VFib on the monitor. They applied pads and shocked ×1. Response was unchanged. CPR started. They called for help from the West Union ambulance. By 5:50, rhythm check, VFib, second shock. Used the AED. Response unchanged. CPR was resumed with BVM ventilation. Paramedic boards the ambulance and intubation 7.5 ETT, 24 centimeters. By 5:54, patient does have some respirations on own. ETCO2 applied, rhythm check, VFib, shock a third time. CPR was resumed, rhythm check, tachycardia with pulse. They resumed transport with extra medic in back, delivering ventilation. They obtained another 12 leads showing AFib with RVR. They contacted medical control for orders. By 6 o'clock, between 6 o'clock, 6:10, they started amiodarone, IV push over 10 minutes in a 100 milliliter bag of normal saline. Patient was fighting tube and extremities, so they administered 5 milligrams of Versed, IV push. Patient calmed, and heart rate dropped from 180 to 140, and they continued to slow with the amio drip. Vital signs obtained 186 over 117. His respirations were 12. Contacted Union via IHERD with STEMI and condition and interventions. No orders were received. By 6:13, the vital signs were obtained, 162 over 109, heart rate of 155, respirators of 17. By quarter after, patient aroused before arriving at Union and again administered 5 milligrams Versed, IV push. Patient was sedated. By 6:30 Central Standard Time or 7:30 our time, care transferred to Union ED Trauma 1. By 8:37, balloon catheter advanced to the target vessel. By 8:43, 95% stenosis in mid-left interior descending successfully stented using drug-eluting stent. Pre-hospital EKG to balloon time was 127 minutes. Door to balloon time was 68 minutes. This was a pretty good run. They did a really great job with their times. And so far, we're 100% for the year. Year to date, it's through April. We don't have May data yet. That's all I got. Thank you. That was a great one.
All right, so our next up is Jackie Martin, who's the trauma program manager. She's going to do our
case studies.
Yeah, reports.
Something like that. Okay, so I had to go back because I picked these like a long time ago and then we couldn't meet. So I had to go back and refresh myself on why I even pulled these. So the two cases I've picked, so I try to pick one that come from a little closer, and I always pick one that come from a little farther away because some of you guys live out in Timbuktu. So I picked both cases that gave outstanding care. Like I thought the medics were spot on with both of these cases. They're both very, very different, and they both represent caring for that emergent complaint, picking that over the less threatening issues. The second case probably brings that to the surface a little bit more than the first one. And they're both examples of how we need to think about the big picture and not tunnel in on the trauma, because it's really easy to focus on whatever that pertinent thing is and forget that there are other things going on. And in the first case, I thought maybe the medics could have felt a little more, like I felt like their personal safety could have been jeopardized, but they didn't really know this going in. And that part of that's just what you know when you get there. So case one, they're actually called for a cardiac arrest. So they get the 911 call at 21:55. Dispatch goes out very timely at 21:57. En route a minute later. They're on scene within just a few minutes. They don't stay on scene for very long. They do a very, very good job on their times. And they get to us at 22:19. So the total 911 to the call to the arrival on scene was 9. They only spent 14 minutes on scene, and the whole run only took 24 minutes. So this obviously is the one that's a little bit closer to us. So EMS finds an unknown aged male in cardiac arrest. They find him supine on his front porch. They note that he's cold and he's cyanotic, but it is also mid-January. It's about 8 o'clock at night, and the temperature's around 29 degrees. So that's not helping the situation, or maybe it is helping the situation. And so CPR is already in progress because fire rescue's on scene. So they talk to the bystanders who say, yeah, we found him about 20 minutes ago, okay? He was unconscious on the porch, so somebody says they start CPR, and then fire rescue and PD show up and they take over. He has an unknown history other than alcohol abuse. He's an asystole, and he stays there since fire rescue took over. They put him on a monitor, he was asystole for them, and that's where he stayed. So he gets 2 rounds of CPR, they do a rhythm check, there's no change, he's still asystole. We know that once you hit asystole, it's really hard to come back, right? They do an extremity lift to the cot and they take him to the ambulance. So they don't spend a lot of time on scene. He's a fairly young guy. I don't remember his exact age. I want to say mid to late 30s. I'm looking at Polly. I don't remember for sure. So they do a really good assessment in the ambulance. And they say that he has trauma noted to his head and face. He's got excessive swelling around his face. He's got a lot of abrasions and contusions. There's no gross deformities, so they don't feel any depressions or anything like that. They put him in a C-collar. They drop an IO on the left side, get some saline going. They follow ACLS protocol. They do try to intubate him, but he's got really crappy anatomy. We all know that's a really hard thing to do. So they end up putting an eye gel in place, and it's good. It secures the airway, and they just continue CPR, and he stays asystole the whole time. So when they call it in as a cardiac arrest, a CPR in progress, okay? But they didn't tell us he had all these facial injuries. So because of that, we don't call it trauma activation, okay? But I'm not gonna fault anybody for that, because what's ABCs? Why do we do ABCs first? Because if you don't have A, B, and C, the rest of it, who cares, right? If they have no heartbeat, they have no breathing, that takes precedence. So it actually would have qualified for a level 1 trauma activation, but we didn't know that when he came in the door. We just came in as a cardiac arrest. And nobody knows that for a while. So it is appropriate to have called it in the way it was, okay? It was still a good run. Had we known that, we maybe would have gotten you a little bit more help, but it would not have changed the outcome of this run. So in ER, the provider in ER notes PEA, I don't know, maybe the drugs are kicking in. Eye gel's in place, CPR is in progress, EMS notes the abrasions to the bridge of the nose. We don't know anything about his medical history. We know nothing. His pupils are dilated, non-reactive. We know that's not a good thing, right? Trachea is midline, breath sounds are present, so the airway is good. The eye gel's in place doing its job. The abdomen is soft and non-stended, so we don't think he's bleeding in his belly. His pelvis is stable. His extremities are in good shape. It looks like it's just facial trauma, head trauma. So there's no crepitus to the skull. His skin is cold and dry. He doesn't have any rashes to make us think he's got something going on there. He's got those abrasions to his nose, to his chest. They do note a laceration to the left upper back. They try to do a bilateral needle decompression, and it doesn't make any difference, okay? Because that's not his problem right now. And so he stays in PEA, and then eventually they call it at 2239. So they called this in the ER. He never went beyond the ER. So the doc notes that when the patient was rolled, they found a laceration in his upper back. The RN notes that he was rolled back and forth in an attempt to find an ID because he is a John Doe, and so that's when they found it. And there was no significant blood on the gurney under the wound. EMS didn't talk about any blood on scene, so I don't think that he bled out externally a lot. So when we do the autopsy, we find that he does have a stab wound to his back. He's got it about 12 inches below the top of his head, about 3 inches left of the midline, tracks back to front, so he was stabbed in the back. Later he contradicts himself a little bit, but he was stabbed in the back. He ended up with perforation of the posterior chest wall between the first and second ribs. He had a penetration of the apex of the left upper lung. He had a hemothorax, and he had hemorrhages adjacent to the external jugular. So he got clipped pretty good. He had blunt force trauma to the head with facial contusions of the nose, around his eyes. He had blunt force trauma to his chest. He had some abrasions. He had a sternal fracture, but you know, we may have done that. There was no significant hemorrhage that they found. He had some cardiac contusions. We did do CPR on him. Blunt force trauma to the extremities, abrasions, that superficial laceration to his arms. He did have a little alcohol in his system, just a bit. Had a little meth in his system, just a bit. And so the cause of death was stab wound to the chest. Manner of death was homicide. So, I see grins, I see chuckles. Remember, this is interactive. I like for you to talk to me too. What are you thinking? Could we have done anything any better? They got called for a cardiac arrest. As far as they knew, that's what they were going on. Okay, I will tell you the neighborhood was a red flag. His home address would have been like, Okay, I gotta be a little careful here. He had bystanders, which may have been his friends, may have not been, may have been his business associates. I don't know who they were. He did get stabbed in the back, so whatever went down didn't go down well. Just 911. They don't ever know who. Jimmy?
I bet his airway was shifted pretty far, that's why they picked him too.
I think so too, even though they, you know, trachea was still midline. I do think so, especially if you think about where it penetrated, you know. Yeah, and he had a hemothorax. Because they say they tried twice. The medic, and it's a good medic that did it. He tried twice, and he couldn't get the intubation, so he drops an eye gel. And he says it's due to anatomy, so it's like, if you did hear what Jimmy said, he thinks the airway may have shifted from the injury. What else? It's a good run. It's a really good run. And even though we didn't know it coming in the door that it was a trauma, it's okay because you were doing CPR. And I have been in your shoes, and I do know CPR in the back of an ambulance sucks. Okay. Anything else?
I mean, I think it's definitely, this was a really, really good run. You know, these are tough cases, like, kind of pull yourself back and think about the H's and T's. Okay, so we know they're arresting, we're managing the arrest. But in the background, I'm trying to think, okay, why do we think this patient arrested? I forgot the age. What was the age?
I didn't have the age. I think he was like late 30s. He wasn't an old guy by any means.
Yeah, so I think one takeaway is like, especially in that younger population, the two things, the most common thing that pops up in my head is some kind of toxicology type thing. But
He was positive for meth. He had an alcohol of 350 something, 352, yeah. So, yeah, at autopsy. So it was higher than that when we got him.
It's probably worth thinking about trauma for the younger, especially the younger folks, or if you see any injuries, like, you can't make deader, so like, you'll never be fault if you dart their chest, thinking there might be a pneumothorax. I don't know, to Jimmy's point, it could have been tension pneumo there, who the heck knows. But just, yeah, that's the only thing I can think of. But again, it's tough because, you know, all our minds, it seems like from the beginning to the very end, everyone's thinking cardiac arrest, primary cardiac problem. But the cardiac is obviously secondary to this trauma.
Yeah, and the trauma assessment, the medic does a really good trauma assessment. It describes all those facial injuries. So we know there was something. I don't know what were you there, Jared, or did you just, okay. So the bystanders, did they help you at all?
So when it was called, they said that there was this random homeless guy, which is, we know that this guy, for the most part, is homeless.
Okay.
And he's a known alcoholic in the area. So when they called, they said that they found him out on the floor, he passed out. They just thought he was drunk, he passed out. The bystander said they came back 20 minutes later to check again and noticed he wasn't breathing.
Okay, so he had laid there for a while.
Yeah, we found out later on, the person that called at that house was actually the perpetrator, who was standing and telling us.
Okay.
We found him like this.
So they're in a situation with the assailant and don't know it. Okay, so that's my take on it. So he went medical and I went safety. It's like you just walked into a bee's nest basically, not knowing it, and it wasn't really anybody's fault other than, you know, keep that in your mind, because what's the number one rule of EMS? It's your own safety, right? And if the situations are not safe, you do not have to walk into them, cardiac arrest or not. So, but I don't know that you got just enough information to know you were going on a cardiac arrest, but not enough information to know that you're going into an unstable situation. Did you ever at any point suspect that guy? So,
We didn't even notice the trauma until we got to
okay.
It was outside, cold.
Yeah, it was cold. It was January.
And once we got into the ambulance, that's when we noticed all the facial injuries. And so we decided to decolor on. We started kind of drawing conclusions to like, this is.
Yeah. And they don't spend a lot of time on scene. They just kind of did what they had to do, and then they loaded him and did the rest en route. So the scene time was really good. So that's my take. Anything else? Good learning experience. Remember, you're number one. Okay, that's when you get to be all about you. I'm safety or not.
The thing was, they didn't really realize. I mean, they were not unsafe until the ER.
Right.
Until they realized in the ER.
It's another one of those after the fact when you get the call going, hey, by the way, did you know?
Team safety was
Yeah.
probably a
Yeah.
safety.
And even, we didn't even know it until we start rolling him back and forth. The nurses chart that they're rolling him, trying to find an ID because he's a John Doe. And when they are trying to find the ID, they're like, oh, hey, look, there's a hole. So, but I'm guessing there must not have been a lot of blood on scene for make you know. Yeah. And they note that there's not in here either. So it's,
I don't believe that he was actually stabbed where we found him.
oh, they think they moved him or he walked or something. So, okay. So case 2 is a little bit different. This one's a car crash. It's a 25-year-old female. She's in a 2-car collision. The other car was a small SUV that when EMS gets there, they find it on its roof. She's a front seat passenger in a 4-door car. They say they swerved to miss a flagger and struck the SUV. Initially on scene, the driver reported that they were going in excess of 80 miles an hour because they were running late for a doctor's appointment. The car went down an embankment into a line of trees. They were wearing their seatbelts and and the airbags did deploy. There's no, this one shocked me, no intrusion into the passenger compartment. They went down and struck the tree. Both passengers and driver's doors were able to be open, so there was no extrication. Driver and passenger both walked up the embankment to the side of the highway. So times are good considering where this was at. This happens over on Route 1. So the call comes in at 9:02, dispatched within a couple of minutes en route, on scene just within 4 minutes, leave scene about 22 minutes later, and arrive here at 9:58. So times are good. So 8 minutes to get on scene, 22 minutes on scene, and a 56-minute call time for beginning to end. And like I said, this is coming from over on Route 1, so that's really good call times. So patient has several complaints. She complains of right shoulder pain, upper arm pain, lower abdominal pain, right ankle pain. She said she did not pass out. She denied any neck or back pain. She complained of chest pain where the seatbelt had been. Said she's not short of breath. She's not sick to her stomach. She does say she's a little lightheaded. She's also 19 weeks pregnant with baby number 3. Thought she might be having vaginal bleeding. So she feels like she's bleeding. Okay. So said the pregnancy had been uneventful. And it says in the report that there's a history of congenital heart defect. I'm assuming they meant the mom on that one. It just wasn't real clear when you read it. She takes no meds. She's alert and oriented. Airway's good. She's breathing on her own. Respirations are good. She can talk in a complete sentence. Pulses are strong. She is pale, okay? So she's pregnant. She thinks she's vaginal bleeding, and she's pale, but she's warm and dry. So when they do their trauma assessment, they said there's a hematoma above the right eye. She has some abrasions on the bridge of her nose, which could be anything. Anything in the car just became an object. She's got abrasions to the right clavicle, medial chest line with the shoulder belt, left forearm, a little bit of bleeding, nothing major, left hip, a little bit of bleeding. Says it's in line with the lap belt, which pregnant women, where are they supposed to put their seat belt? Down, supposed to be down under their belly, on their legs. That's the only people that get to do that. Right ankle pain, but it's not swollen, and no abnormalities to the neck and back. So she's got some bumps and bruises going on. So I tried to put a seat collar on her, but it hurt her so bad in her shoulder and clavicle that it couldn't be done, okay? She stood, she pivoted to the cot with the help of a couple of medics, and then they put her semi-fowlers on the cot. So they took her clothes off in the ambulance appropriately, and they could not find vaginal bleeding, okay? So she feels like she's bleeding, but there's nothing external, okay? That's a flag. She's 100% on room air. She's sinus rhythm. She's doing okay. She's pretty young. I don't remember her age, but she was a pretty young girl. They get a 20 gauge in her. Her pressure's only 86 systolic, okay? That's another red flag, right? So they put her supine, which probably didn't do real well. They start some fluids on her. They can get her now up to about 90, which is better, but still not great. Blood sugar was fine. They put ice packs on her ankle. They didn't give her pain meds, so kudos to the medic. They did not give her pain meds because she was too hypotensive. So we call it a level 2, but we really should have called it a level 1, okay? Because her blood pressure was too low. So now they're saying, oh, no, we were only going about 60 miles an hour because now PD is here, fire rescue is here, everybody's asking them questions. They went off the road to avoid another accident. Seatbelts and airbags. Said she had pain to her abdomen, chest wall, shoulder, and ankle. Vitals are okay, not fantastic for a pregnant girl, okay? Assessment's negative, except her belly is soft. It's non-tender, non-distended. She's got normal bowel sounds, but she has a seatbelt sign. That's huge in the world of trauma, okay? That is giant in the world of trauma. I have a seatbelt sign, which means what? I have bruising where? Across her belly, okay? She feels like she's got vaginal bleeding. I got bruising across the belly. She's got crap for her pressure and she's pale. So we call her OB, who says, get a hold of OB hospitalist. And that's okay. The reason he did that is because the OB hospitalist is literally around the corner from the ER. So the OB hospitalist comes over, works with our guy, says, I want to do a bedside ultrasound. Well, guess what? He can't find a fetal heart tone. Okay, we're going to ultrasound. So ultrasound says we find a 19-week, 5-day baby, one baby. She has an anterior placental abruption. She has a possible umbilical cord abruption. She has no fetal heart tones, and the ED doc and the OB hospitalist both go to ultrasound with her, so they know this is serious. So we admit her for an emergency delivery, so she has to actually deliver this baby. She gets a D&C. Afterwards, we do x-rays because that wasn't the life-threatening injuries. So afterwards, we do x-rays and find that her clavicle's broken and her ankle's broken. So our clavicle did require surgery, her ankle did not. There was a little bit of miscommunication between ER and OB nursing staff because, one, OB does not deal with trauma, right? That's not their world. My best friend is OB. She said they have a certain zone they go to and that's it. I said, you give me a good gunshot any day. So they don't deal with these patients. So they felt like we should have addressed the ankle and the shoulder, and we're like, but it wasn't a priority, right? Her life was a priority. Her baby was a priority. Her bleeding was a priority. She did go home on day 5, and in between there, her boyfriend had left her. He tried to commit suicide. We tried to get her some grief counseling. She wasn't receptive to that. She was done. She was over. I do know that the driver of the other car died, and he technically died on scene, but I think they pronounced him at the other trauma center. So, thoughts, opportunities. What could we have done? What could we have not done? What should we have done? They did not. That helps us. One of the things I look at every month when Misty and Polly bring me the reports is I look to see what your scene time is. 20 minutes is your goal. I realize that sometimes it takes a little bit more than that. And when I look at your narrative, it's like, oh, I was on scene because the guy was going crazy. Or we were on scene because it took us a while to extricate him. So we look for those, but no, they did not. What else?
So one thing, and you mentioned it, I think already, about the soft blood pressure, low blood pressure, lying supine. For the pregnant patient, you may want to lay them on their left side. That puts less pressure on the IVC, so you get better venous return, better blood pressure. That's one thing. And then, sometimes a little bit of hypotension can be normal in a pregnant patient, but in the setting of trauma, I do agree, true hypotension until proved otherwise.
Yeah. And she said, I think I'm bleeding. Enough to where the medic disrobed her and checked it and didn't see anything. So yes, she was, and probably felt that. She just wasn't bleeding externally. She was bleeding internally because her placenta had abrupted, and we think the umbilical cord may have abrupted as well. So what else? So both cases show you how it's easy to zone in on that critical piece. And even though, yes, we need to make that a priority, and that's what we need to do, we need to not lose track of the whole picture, okay? So that's my take on it. Anything else?
You said the blood pressure, you call it a level 2, but the blood pressure itself.
Yeah.
Shouldn't the rate of speed?
The rate of, yeah, all of those factors. So the rate of speed was, the story was changing, but I think it was because they thought they were going to get in trouble. And obviously this guy wasn't really the most upstanding baby daddy. But yeah, so we have criteria that you guys don't, like, once you say, hey, this is what I got, then we have criteria where we look at that and go, oh, well, they fall into the 1 or the 2. So that's something that we actually are struggling with right now. When the pressure drops below 90 with a mechanism of injury, we should call that a level 1. And what we can't get our people to wrap their brain around is they're probably bleeding like she was. And even though you can't see it, that blood is somewhere. And so these guys, and so that gets the docs in the room quicker, and a 1 will get you a trauma surgeon a little quicker. And so it just helps us get the resources in. So yeah, the speed, the mechanism of injury, they went down an embankment and struck a tree or something, I can't remember now. The pressure was low. She had signs and symptoms of shock. She had a huge mechanism of injury. Yeah, so we definitely should have done a little bit better job there. We do fast, and they did a bedside just for a quick heart tone on her, and then we shipped her to ultrasound. Yeah, but yeah, we definitely do fast in the ED. Fast, remember, is the bedside ultrasound so they can look for blood in the belly.
And when you guys are like on scene, like you guys could really have a huge influence on us. So we have our criteria for sure, but you guys are actually seeing the patient, And if you feel like, oh, this is not, there's something more to it, like you can advocate, like, I got a really sick trauma, the vitals are stable, but it's safe. Because there's some gray area as well, right? So like, we will never be upset. If someone's upset at you, like, let us know. But if you feel like someone needs to be a level 1 and they don't perfectly fit in those boxes, that's okay. Like, if you think it should be, like, let us know.
It's always, yes, it's always better to go up than to call it low, because a level 1 gets you everybody. It'll get you a trauma surgeon. It gets you the blood bank. I can't even think the whole list right now. Like radiology, everybody is in the room ready to go. Whereas a 2, we have to call them in. So you're kind of behind the 8 ball if we call it a 2, or if we don't call it at all. So the more information you can give us, I'm not talking about like, they had orange juice for breakfast and an appy when they were 10, but the more information you can give us about the scene, about what you see and what your gut's telling you, because you guys were there. And I know you have some issues when you get there. And like Dr. Bassi just said, if you have those problems, you need to let one of us know and we will definitely address it. But years ago when I was charged, I would look at you, and I've done it to several of you in this room, and I'm like, do you want a room or a trauma room? I really think this is a trauma. Okay, then we're going to trauma. Because I wasn't there. I didn't see the car. I didn't see the wreck. I didn't see the fall. I didn't see what the patient looked like 15 minutes ago when you first got to her. Because you did interventions. So, their pressures went up. It wasn't great. I can't remember, it got up to 90, I think, or something, because they did an intervention. But she wasn't there when they first got there. So that mechanism is still there. So both were really good runs. Both were well documented, other than, like Jared said, they didn't tell me why they were 22 minutes. I gave you a little grace period on that. Other than that, just don't zone in.
As an EMS, though, our responsibility is to report, I have a trauma alert.
Yeah. And then we decide.
But then we paint the picture
Yeah.
for you that allows you to pick 1 or 2 quickly. That's where we can be better at, and we can do that.
Yeah.
But then to me, that's the difference. We cannot say, this is a level 1.
No.
We may know this.
And that criteria changes. So as American College of Surgeons changes things, we change our criteria. Or we may say, in our area, we see a lot of. And because of that, that's like the geriatric head fall, a fall with a head injury. If you have an old person that falls with a head injury and they're on an anticoagulant, we chose to make that a trauma alert, because that's something we see a lot here. And we were seeing head bleeds, and we were seeing significant cervical injuries and things like that. So because of that, yeah, we chose to make that an alert. That's not something we would ever ask you to do. But what I want you to do is say, hey, grandma's on anticoagulation and she fell and whacked her head on the dresser. Oh, okay, well, we're going to call that a level 2.
We should probably more for talk about in the future when we have like potentially pregnant patients, we want a protocol where the OB hospitals come down rather than trying to figure out who's coming to the OB and the primary. Maybe we just designate the OB hospitalist.
Like make a separate, or yeah, we could talk about that.
Just if even the baby's not viable, they're like this mom would have died.
Yeah.
Yes.
She would have died.
Yes.
So even though that's not a viable baby, we're not taking the baby, we have to save mom.
Yeah.
Yeah.
Right now, it sounded like, and I don't know how much time it took to figure out who's gonna respond, but it'd be nice if they just designate them and they just come right down, so that's one less thing for us to worry about.
Yeah. How about pre-hospital? Anything else? Like I said, both runs were good. Both runs were handled very, very well by very good medics. Documentation was great. It's just don't zone in on that bad thing, because there's a whole lot going on with both of them. Okay.
Thank you, Jackie. All right, up now is Jimmy McKenna. He's going to do a talk on capnography and some other little tidbits and things. Stand there and wear this. I have to stand there. Yeah, there's a video. I'm not good about staying in one spot. All right.
I know, I'm a mover. All right, I'm gonna try to stay in this one spot right here. So my name's Jimmy McKenna, respiratory therapist here at the hospital. And I'm just presenting, I'm actually re-presenting something that I had done in February at a respiratory conference here in Terre Haute, specifically about capnography. And it's kind of like one of my passions, capnography, because it's kind of next level respiratory therapy. So, I'm sorry, yes, I need to be right here. So, anyway, I'm going to get into kind of, it'll be a little bit deep. So, try to stay awake if you can. And then I like to be interactive too. So I will ask lots of questions, but I don't like awkward silence. So if there's awkward silence, I'll just answer it myself. So, but feel free to answer questions. So let's get started. So the best thing to start any capnography is talking about earth science. Now, who likes earth science? Okay, maybe a little bit. Yeah, okay. So to know about CO2 in the air, you have to know what the pressure of the air is around us. Does anybody know what the pressure is of the air around us? It changes. Well, let's say it's sea level. 760 millimeters of mercury is the pressure, or also known as 1 atmosphere. So 1 atmosphere is kind of the easy answer you have there. But of that pressure at sea level, which is kind of what we go by around here, we look at different types of molecules or gases in the air we breathe. So the vast majority of the air we breathe, 78% is nitrogen, which we all kind of understand that. 21% is oxygen, and that's 21% of the 760 that's right here. And then we have 2 more blanks. Would anybody like to take a guess of what the 0.93% is? It is a noble gas. That probably didn't help. Argon, absolutely. Argon, great. Argon is the next one. And the point, that's really good. You know your noble gases, I'm telling you. So, but you really don't. So, you Googled it. So 0.93 is argon. 0.04% is actually carbon dioxide. So just to look at it this way, it's carbon dioxide in the atmosphere that we're breathing is 400 parts per million, but that breaks down into 0.04%. And if you look at it, how much of it's in room air, if we're looking at millimeters of mercury, where we're looking at how much is available in the blood or whatnot, it's 0.304, a very, very small amount. Argon is actually 23 times stronger than CO2, or 23 times higher. So that's the great thing that we can use in medicine to monitor ventilation. When I say ventilation, I'm always talking about CO2 exchange, is carbon dioxide, because there's not a lot available in the air around us, is mainly being produced by the human body under normal cellular respiration. So what produces CO2, or how is CO2 produced? Well, it's actually produced by the Krebs cycle. We are not going to talk about this today. This could be really big. This is just a filler. So that might take a while. But who do we blame for CO2? Now, there's been a lot of blame thrown around. What is it? Actually, the cows is one of them. Susan's right on. Is it the cows, or is it the cars? Is it the factories, or is it the big gulp? Okay, is that the problem? Does anybody remember the Biggie from, you guys do, right? From Wendy's? This is my fave. So, the Biggie. So, is it those? No, it's not those. Who do we blame? We blame the mitochondrion. So, this is not the same narrative that you're going to hear in the news. We blame mitochondrion because that's where all this takes place, and CO2 is released from the cells, so in large amounts. So vital signs, and the title of this is the 7th vital sign. So don't you like how we just keep adding vital signs all the way down to whatever? But in a lot of the different studies that I've done, they put capnography or exhaled CO2 as number 7. So we know what they are, all the way down: oxygen saturation, level of consciousness, and end-tidal CO2, which is the number reading, with capnography, which is the waveform that can be used diagnostically. So what is capnography? Definitions are right here. Capnography, of course, is the measurement of CO2 that's breathed and an exhaled breath. A capnometer is something that gives us just a straight number. So like a 35, 36, 52, doesn't have the waveform. A capnogram is the waveform, and end-tidal CO2 can be EtCO2, PeCO2, that's the partial pressure of CO2 exhaled, and that's released at the end of exhalation. That's the best one. Where can it be used? So number one thing, we use it a lot with patients with sedation. So if we're sedating a patient and instead of watching their chest rise and just taking a wild guess of like, okay, this is an adequate respiratory rate, but is that adequate tidal volume? We don't know that because ventilation is determined by two things, respiratory rate and tidal volume. You can have one and not the other. You can have one tidal volume and not have a rate. So we want to know that they're adequately getting rid of CO2. And so that's what this number gives us. So that's the first one. The next one we use it for, and you guys know this, is with the ACLS algorithm, of course, with monitoring effectiveness of CPR. And this one is this is an old school picture of a pulmonary function machine. And so it actually, during a pulmonary function machine, this shows CO2 tells us about your pulmonary function actually, because the way that you get rid of CO2 and the way your waveforms look can tell us a little bit about obstructive and restrictive disorders inside your lungs. And then listen to breath sounds. I'm not sure why I put this picture on there. I just thought it was funny. They put it was like listen to breath sounds and they put it on their stomach. So there's usually not breath sounds down there. So end tidal versus PA CO2. Now in the field, you don't get an ISTAT. Unfortunately, it'd be really cool to do blood gases and look at all this kind of other stuff. But in the hospital, we use PA CO2 because we're looking at that from a blood gas standpoint. Well, how does it compare? Exhale CO2 is always going to be lower than somebody's PA CO2. And the gap is usually 5 to 10 in difference. So you see normal PA CO2 is 35 to 45. Normal exhaled CO2 is 30 to 43. Now, if that gap increases throughout their stay, that's going to tell us about their lung function. But one thing it does do, like any other vital sign, it's a trending tool. So if you know anything about blood gases, which you may or may not, if you get a blood gas, the normal PaCO2 is 35 to 45. That's a 10 millimeter per mercury range. So when you are going to do exhale CO2 on a patient, and at the exact time we do exhale CO2 and it says 35 on exhaled, and we do a blood gas and it says 40, we know that there's a 5 difference. Well, you don't get the opportunity to do a blood gas in the field. But what you can do is start with that 30 and you look for a deviation from that initial vital sign by 10. If that increases by 10, that means their arterial increase at the same amount. And you can see your arterial has a 10 range. To actually, if it gets outside that range, your pH on the top side, your pH is going to be down. On the bottom side, your pH is going to be up. So to make pH changes, you're going to see a 10 millimeters of mercury fluctuation from your baseline end tidal CO2. That's how you use it as a trending tool, because you might pick somebody up and they could be an exhale CO2 of 62 and then that be their normal day. What you're looking for is from them to go from 62 to 72. Because at that point, when they fluctuate by that much, you know that their bicarb can't make up that amount of space in a time of a run, so their pH is dropping in that case. So it's kind of a way to look at acid-base balance without having a blood gas machine, exhale CO2. What other problems cause the bigger gaps in here? VQ mismatches, ventilation perfusion issues, which can be pretty much any type of lung disease, acute lung or chronic lung disease, and then dead space ventilation, which we don't have to worry about that much in the field. So we look at the waveform, and it's totally backwards to any kind of ventilator or waveform you see at all. So a pressure ventilator waveform, of course, pressure goes up during the breath and then falls. This is when the patient takes their breath in, this falls to the base. And then it begins these phases as they exhale, and then the number, the capnography or the end tidal CO2 number, comes from right here at the end of exhalation. This waveform is really important. So you got to think of it this way. If they take a breath in and they go to exhale, this initial phase and even in phase 2, when you start to exhale, you're not dumping your alveoli. You're dumping all your conductive airways. So that's from your lips down to your terminal bronchioles. There's many branches in there, and it's about 100 milliliters of volume of air for the standard adult. So when you first start to exhale, it's mixed air. You got nitrogen, you got oxygen, you got a little CO2. So the CO2 is never actually going to come up really nice to the top platform right here. But you're going to see as you start, and right here, you've emptied those conductive airways. Now you're emptying alveoli. Okay, so this is going to give you the best indication of what their exhaled CO2 is. And the angle of this, flat, angled, or whatever this is, can tell you how their alveoli are kind of dumping when they're going to exhale. Tells you a lot about what's going down on inside the patient without even looking inside the patient, so, or having an x-ray. So if you look at these waveforms, there's some diagnostic stuff you can do. We'll talk about that in a second. So you can see how it kind of compares. This is pressure, tidal volume, and flow, pressure, and tidal volume for a ventilator waveform. So uses of capnography, many different things you can use it for. Go through these real quick. We talked about sedation, a determination of Ross, compression effectiveness, and disease differentiation of bronchodilator response. So these are our three we'll go over real quick. First thing is that you always want, and I know that medics are really good with this, is knowing the difference between oxygenation and ventilation. So you can have one without the other all the time, and those are two separate areas you have to address, is oxygen and ventilation. So oxygen we're talking about, their SpO2 is the easiest way to find that. And then for ventilation, we're talking about their CO2, so pulse ox and capnography. Those are two areas. The great thing is if you have a pulse ox hooked up and capnography hooked up, you actually have 4 vital signs there, because your pulse ox should give you, as long as you've palpated it, an accurate pulse rate. So there you got pulse ox and pulse rate, and then capnography gives you a really accurate respiratory rate. So it has the ability to kind of like, they look 16, they look 18, oh, they look 20, maybe I have to do something now. Not that you've ever made those up before, but maybe just respiratory therapists do. So we look at their respiratory rate, but you're going to look at variances in their respiratory rate and changes from their baseline. So you get 4 vital signs out of hooking those things up. So interesting strip, I've presented this before. It's really kind of cool. So if you're watching their EKG and their pulse ox, and we've known this before, and I've actually done tests on it, I think with Terre Haute Fire when I've done some stuff, is where you put capnography on somebody, you tell them to hold their breath or go apneic as long as they can. What's going to happen to their heart rate? Usually nothing for at least 30 seconds. What's going to happen to their pulse ox? Sometimes it goes up because they go like this and hold their breath like that and recruit alveoli. So pulse oximetry, and we found this in the hospital, is such a late sign of decomposition. If somebody's pulse ox is low, they are going to die very soon. They're going to code. But capnography is our early warning sign that, for one, if they're not breathing, that's one for sure, so that I can pick up and that will alarm. But for 2, they're not breathing adequately. So CO2 is that early warning sign. And unfortunately, there's pulse oxes all over the place. You can buy them on Amazon for like $15 now. And I'm sure probably everybody you go see their house, they probably have a pulse ox that they have it on their fingernail with nail polish or whatever. So there's a lot of inaccuracy with pulse oximetry, whereas capnography is that really good tool to look for early warning signs. So for a case study, this is absolutely, Jimmy made up this case study, so this isn't real. I'm just going to be straight up with you. So, but this is a case study made up by me. A 65-year-old male patient comes in with left shoulder pain, deformity noted, and has dislocation. So I'm not going to get real technical with it, but vital signs obtained. We got 2 liters of nasal cannula oxygen given 5 milligrams of Versed, and the respiratory rates are monitored. So in the past, for any conscious sedation or anything like that, respiratory therapy would come and quote unquote watch the patient. So what do? I would look for chest excursion. That's what I would have done. Just looking directly at their chest at all time, look at excursion, because you're taking kind of wild guesses on what their tidal volume is at that point, and their respiratory rate. So the respiratory rate can remain the same, but the tidal volume drops. That can be a problem. In this case, 3 minutes post-procedure, you got a respiratory rate of 8, and the other one has a respiratory rate of 24. Well, it's really nice to have respiratory rates, but the most important aspect of it is what is their exhale CO2. So in this case, we had exhale CO2 on the respiratory rate of 8. Exhale CO2 is 39, which we know even 5 above that is still going to be really close to normal range. And there's the waveform on that one. And patient B has exhaled CO2 of 24. So respiratory rates can be very deceiving, because even though their rate's 24, this patient B's volume was extremely low, not enough to adequately ventilate the patient. So That's the problem. What about the tidal volume for this patient? And you really can't measure that unless you're doing capnography. So one of my favorite respiratory equations in the world, one of my top 5 favorites. So I got a lot of them, but this is my real favorites because it's very easy, very simple, but it makes a lot of sense. And one of the things that we always look at when it comes to ventilation is minute ventilation. So MV is this. So it's a very simple equation. This equals this, but they're the same thing. But what we do, we figure up in respiratory medicine is, okay, I have this tidal volume and this CO2. Well, my CO2 that I really want is 40. So I put in 40 as the unknown, and then I solve for X. A little bit of algebra, just a little dabble of it today. So we're going to solve for X in this case. So where do I get minute ventilation from? Well, you do your tidal volume times your respiratory rate. And my exhale CO2 is 52. So they're not doing real good right now. I'd like it to be 40. What do I need their respiratory rate to get to or their tidal volume to get to? Now, this is a little bit more like vent management stuff. We'll go through it because it's kind of cool. So simple math, 600 times 12. Do this stuff, divide it by 40. That leaves X as 9.36 liters. This is nothing you're going to figure up on your run through town to get over here really fast. But this is just to prove a point. This is your minute ventilation. So this is what's going to go right here to make this 40 because minute ventilation is directly proportional to their CO2. So there's many different right answers for this. So if I'm managing a ventilator, there's many changes I could make to make this CO2 40. I can make one change, definitely. Change the respiratory rate, leave it at 12, turn the tidal volume to 780. Or I can take the respiratory rate, put it on 14, put the tidal volume to 668. Or respiratory rate 16, tidal volume of 585. And that's why we get into, and this is kind of how it relates to current state of ventilation. This is how we get away with running really high rates on ARDS patients, specifically viral infections and COVID patients, because we drop that volume, but we increase the rate, and we can still maintain a minute ventilation. So that's what we're doing in the ICU to help protect people's lungs. So we drop the rate, and although we're not writing this equation out, we're kind of doing ballparks in our head. But this is the really cool thing about minute ventilation CO2 is this makes sense, and this actually works when you make these changes. But that was my rabbit trail that I go down. So we'll stop there. So 2010 to 2015 AHA capnography guidelines state, and you guys know this, we've talked about it before, continuous waveform capnography is recommended in verification as another clinical confirmation for the placement endotracheal tube. We know that. Capnography is really good for that. And it's also good for CPR quality. So using the quantitative waveform, so looking at the waveform capnography quantitatively to tell if we have good CPR and also to look for early signs of ROSC. So the determination of ROSC is, so if we have ROSC, we're going to have an abrupt increase in their exhaled CO2. And a lot of times it's going to be seconds before you're actually going to be able to feel a palpable pulse, which is kind of cool. So you can almost be like, you see a CO2 coming up, be like, they're going to come alive. And then they will come alive if you can predict it right. So you can almost like predict the future. No, it's not used for that, but it could be if you want to sound really cool. So, but capnography is actually going to show an abrupt increase as the cells and the tissues actually start getting perfused again before you might feel a real good palpable pulse. So it's also a good thing because a lot of times if you're in a code for a long period of time, we're feeling for pulses in the groin or the carotid. I feel one, you don't feel one, feel this, feel that. It's really hard to tell. And some people get real excited, and so they feel one all the time. But capnography is one of those things that kind of takes that aspect out of it. Because if you get that abrupt increase in their CO2, yes, they have a pulse. But the great thing is it's actually perfusing, and their body systems are starting up again. In the fact their mitochondria are releasing CO2. So ROSC and CO2 or CPR quality. So you see on this waveform here, we have CO2 over time, and you see exhale CO2, and then you see a little burst in it, and then you see little drops. So likely during some of these times, these are changes in people doing CPR. So your compressor was a little tired here. You got a new one in here, and then this guy's a little mediocre here. But you should get an adequate normal exhale CO2 during CPR. The baseline that we want is 10, at least 10, which is not super hard to do. So, and I'm saying that from working in respiratory management and not doing CPR in the field. So you should really believe me, right? Yeah. Yeah. So anyway, exhaled CO2 here. This is a really cool one to show ROSC. So we have exhaled CO2 over time. You can see this is very low. We get ROSC at this point. So this is nothing to do. We have no ECG monitoring here. This is just exhaled CO2. So you see when they get their pulse back, it pops up, and then it goes back down when they lose their pulse. And then we get a pulse back here, very adequate. You see it come up really quickly, it drops again, there's CPR, and then it comes up again. But these are all times when they have a perfusing pressure. So it's great to be able to have a strip like this from your monitor in those cases. Some other updates, and we're getting close to the end here. AHA updates when looking at supraglottic airways. So AHA has been real hesitant to say anything about verification of placement of supraglottic airways with exhale CO2, but I know it says, however, effective ventilation through a supraglottic airway should result in a capnography waveform during CPR and after spontaneous response to circulation. So supraglottic airways, they're going to sit above the vocal cords. They are going to get a high concentration of CO2. We know that. And in most cases, you're going to get a very accurate readout, especially if the supraglottic airways either has a cuff that's down in the esophagus and it's blocking esophageal air, or the actual mask is kind of down in that area in an LMA type of situation. But one thing you want to think of is go back to the very first slide and think about the amount of CO2 in the air we breathe. It's extremely low. So being able to monitor supraglottic airways, or if it's placed correctly, you're going to get a great increase initially when you put these things in. So I think there's going to be some more guidelines come out when there's more studies about supraglottic airways, and I know that you use those a lot. Of course, an ET tube is what you would prefer. It's what everybody would prefer, but sometimes it just can't happen, like the case that Jackie presented. So those are very difficult intubations, especially if you don't know you're looking for the shifted airway. So, and then AHA quality for CPR, if it is below 10, you got to change compressors. So termination of CPR, these are some other things. This 1997 study by the New England Journal of Medicine looking at levels of exhaled CO2 below 10 for 20 minutes and stopping CPR in those cases. And then they talked a little bit more about it, and these are some AHA guidelines that I kind of put on here. So they're showing that capnography below 10 for 20 minutes is associated with extremely poor chance of ROSC and survival in patients. So another great thing to kind of add to your, if you have a long on scene or whatever you have, or a long transport, to know that even though you had good CPR, your exhale CO2 was below 10 the whole time, this is going to have a real poor chance of getting ROSC on this patient. So also used for intubation confirmation, which I think is really important. So you intubate, you have your confirmation tools, your breath sounds, whatever else you use, but this is really, really important because we have, with exhale CO2, you're going to have that stamp, especially if you put the monitor on the end of your ET tube, you're going to have that stamp showing my tube was in at this time. And it's usually after 3 to 5 breaths. Now, there's always a thing that somebody will bring up about, well, if somebody just drank a Coke. Yes, somebody just drank a Coke and they coated and it's still bubbling in there. Yeah, they will have a little CO2 in their stomach. Super rare that that's going to happen. But after 3 to 5 breaths, that will be gone. So that will be absolutely gone. And if the waveform starts at 20, goes to 5, goes to 0, the tube is in the stomach. If it starts at 20 and 20 and 20 and goes up or stays up in that area somewhere, the tube is in the right spot. So ideally, we're looking for 30 to 40. It gives a proper timestamp too for when your endotracheal tube was put in. and it's not used, can't be used for assessing for bilateral breath sounds. Of course, we use stethoscope for that, but it can't detect a right stem intubation because think about this, it's not looking at volume of air, it's looking at pressure of air. So you're still going to get response if you go on the right main stem. Your CO2 is going to come up, your tube's going to be in, but then you go to your the equalness of your breath sounds to see if you need to withdraw it a little bit. Or if the hub is at their teeth, that's probably not a good thing either. And then maintaining their airway, confirming maintaining the airway for intubation. So you can see that you can make sure that endotracheal tube's in the whole time, because the most likely time for it to come out is going to be moving the patient from one bed to another. Using capnography the entire time, and your systems hook up to our systems is really important for that. So this, of course, shows continuous, and then this shows where they didn't have it, and then this is actually doing somebody's breathing on their own, so their CO2 is low, and then they're quickly intubated, and then you see a nice exhalation of CO2 there. The last part is differentiation of diseases, and I think this is the coolest part, but I won't spend a ton of time because I'm running out of time, but I do have time? Okay. I was going to start talking like the Micro Machine Man to get done. So disease differentiation. So not only do you just have the aspect of CO2 with CPR and the tracheal tube, but you can actually look at what is going on inside their lungs. We talked about this with the different phases of their CO2 waveform. So you see this is called a shark fin. And one thing that it means is that your alveoli, because we talked about phase 1, phase 2, and this is phase 3, this is all kind of meshed into one. Your alveoli are all emptying at different times. So when they're exhaling, everything's not emptying at the same time. Well, why might that happen? Bronchospasm is the main one. So you have bronchospasm going on, and you're going to have air squeaking through airways as they exhale, and then you can have this shark fin effect. The cool thing is that if you look at the shark fin, you can see a response to your bronchodilators when you use shark fin. So see this case, this is upon arrival, not a great waveform, but we start the first treatment, major shark fin, and you see the little changes in it, the vibrations. You also see that in pressure waveform if somebody's wheezing. So sometimes I can walk in to see a ventilator room, and you see the waveforms, and you know they're wheezing before you even put a stethoscope on them, because you can see the changes in the waveforms, the sawtoothness. You can see a little bit with this, but not a lot. But anyway, so you see a shark fin, and they gave, this is combi nebs, so I'm guessing these are duonebs, gave 2 duonebs, and you see what happened in this case. Not only the patient probably said they feel better, but you treated their problem, because you can see right here and right here. What did you do? You took it from unequal alveolar emptying, raised that phase 3 right in here, brought it up, so now they have more equal alveolar emptying, so you took care of the bronchospasm. Their lung sounds are going to sound better in this case. They're probably going to be more clear, or they're going to have more wheezing, which more getting more air out. So improved breath sounds, but you got capnography to show what's going on inside there is appropriate for a breathing treatment, which is kind of cool, because I kind of feel like we throw a lot of breathing treatments at people and we never really know if they work. So another great thing is to look at the difference between CHF and COPD exacerbation. So everybody in View County probably has a combination of this, but it's really hard sometimes to tell, is it a fluid issue or is it a bronchospasm issue? Well, if it's a fluid issue, throw in albuterol, it's not going to do anything. It looks nice, and you got the aerosolized medicine flying around, but it doesn't do a whole lot. Now, the aerosolized medicine flying around these days isn't quite as nice, but that's just the recent situation going on. So, but if you have expiratory wheezing present, which you could have wet wheezes or tight wheezes or whatever, but sometimes it's really hard to differentiate. But then you put capnography on somebody, and you see this is their capnogram with expiratory wheezing, you're going to notice, what do you notice here? This is equal alveolar emptying right off the bat. In this case, this is going to be more likely be a CHF patient, because they don't have the bronchospastic aspect that's going to cause, that causes the shark fin. Because with CHF, they'll have more equal alveolar emptying. It's just going to have fluid present in some. So with that one, you can definitely see that using waveform capnography can differentiate between those two disease processes, which can be kind of difficult sometimes by shorter breath. And then it's also really good for monitoring CO2 if you have a head patient and you want to get them down to that lower end of normal when you're ventilating them, so you're not going too fast. So having a good number to start with, getting their ventilations down. So any questions at all? I have a YouTube page. If you're not a subscriber, please do. I had 4,000 subscribers. COVID was good to me, so I have about 7,000 now, so in about 3 months. So a lot of respiratory things. And if you're interested, you can take a picture of that with your phone and subscribe and comment and throw stuff in there. I got a lot of really cool people that follow me. There's a lot of these are respiratory type devices and things you might see in people's houses, but there is a big push with respiratory therapy in like Saudi Arabia. So I've got a lot of people from Saudi Arabia that follow me because we use the same textbooks, which is really cool to take care of respiratory care. And so people all around the world commenting in. So it's kind of a cool little area if you're interested in anything pulmonary. Questions at all? All right, thanks.
Thank you.
Yep.
All right, guys, that's going to be it. Make sure that you signed in. We'll be back in. We'll do it again in August. We'll see how things are going then, but we'll probably be doing what we're doing now. We're going to Zoom all the time. All right, after that, I stop recording, get this taken care of at some point in time, and then by the end of the week, I'll have this uploaded to Union EMS webpage, YouTube page. Go out and subscribe to it too, because you can actually watch all the audit reviews from last year and starting this year. Not the one from April because it got canceled. But anyway, other than that, so anyway, questions for me? Comments, concerns? Susan, anything? Dr. Bossy? Dr. Worley? Thanks, guys. Appreciate it.